In this video, we're going to talk about what the initial workup looks like when you see me in the medical weight loss program. The number one thing that we do is vitals. Checking for your blood pressure, your heart rate, your body mass index is the first assessment we do. The next assessment includes a detailed body composition, either using a DEXA scan or an InBody scale. This helps us assess for muscle mass, fat mass, body fat percentage, segmental lean analysis, and basic metabolic rate. This is a very helpful tool and more accurate than BMI alone. I will do a dedicated video on this InBody scale for you to better understand what the body composition means. The next assessment when a patient comes in is a very detailed history. Taking a history in patient with obesity is very complicated. It is multifactorial, nature of the disease, and it can span an entire lifetime from starting in the uterus, factors that determine your prenatal stages, to stressors and hormonal changes that occur as people go through life. It is extremely important for me to take the history with empathy and compassion. It helps me to get better sense of age of onset of obesity, any history of trauma or abuse, any contributing events associated with weight gain, for example, cessation of smoking, pregnancy, menopause, depression. We go into details on prior weight loss attempts as well, and if there were any modalities that worked for successful weight loss, as well as how long that the patient was able to maintain that weight. That can help me understand what the treatment plan could look like. The next step is also to have a detailed history of any eating disorders, such as anorexia, bulimia, binge eating disorders, restrictive eating disorders, or disordered eating. History of any significant alcohol or substance abuse is also important. Then we assess family history. Obesity runs in the family, and due to shared genetic characteristics, it's important to know if it does. And then any history of premature heart disease, cerebrovascular disease, coronary artery disease, stroke, diabetes, cancers in the family, all of that help me understand the risk factors. Then we go over the current medications that the patient is on. Medications can be a significant contributor to weight gain, and if I discuss with the patient if we are able to change them to a more weight-neutral option. The next step is to get a very comprehensive intake of daily eating pattern, your habits, your approximate caloric intake, any areas of problem eating, physical activity. This assessment reveals areas for intervention. The assessment of these variables will continue throughout the treatment plan as well. We go over detailed food logs, meals, snacks, beverages, cravings, late-night snacking, daily routines, work schedule, composition of food, if it is home-cooked or carry-out, if you have time to meal prep and plan, or do you rely on carry-out most of the time. The next step is to assess for physical activity. Now, most of the jobs these days are desk jobs and frequent sedentary behavior, and there is less time for physical activity, and these are independent risk factors for increased weight, cardiovascular disease, and type 2 diabetes. A lower amount of physical activity has also been associated with high all-cause mortality, which means all-cause mortality means increased risk of death, independent of the effects of BMI, which means it's independent of the effect of weight. Increased physical activity improves initial weight loss only slightly, but it is a single best predictor for weight loss maintenance. This is why it is important to lay a solid foundation of exercise regimen as you work on a weight loss strategy. The goal of this assessment is to assess patient on a continuum that ranges or can range from being completely sedentary to someone who's a marathon athlete. That way, we also know where they're at and meet the patient there. I also ask about if they track their physical activity with any wearable devices like pedometers or Fitbits or Apple Watches, so we have an objective assessment of their physical activity. Next, I screen for mood disorders. Obesity is associated with increased risk of depression, anxiety, and it's also important to screen for current substance abuse, alcohol abuse, insomnia, and if it is being treated appropriately. If I feel the need for the patient can benefit from a psychiatric or psychological therapy, I make the appropriate referrals for them. The next step is to order a comprehensive set of labs for diagnostic evaluation. The workup includes checking for blood counts, any signs of iron deficiency, kidney function, liver function, fasting cholesterol panels, A1C, fasting insulin and glucose levels to determine HOMA-IR, and also vitamin D and B12 levels. Based on history, additional tests may include ruling out Cushing's disease, acromegaly, insulinoma, polycystic ovarian syndrome, congenital adrenal hyperplasia, and also sometimes checking hormone levels to assess for perimenopause, menopause, low testosterone levels in men and women. Sometimes it's also necessary to obtain a baseline EKG if we are going to treat with phentermine or stimulants for binge eating disorders. This comprehensive workup and history helps me determine the genetics, the environmental influences, the social and psychological causes, and history of all previous weight loss efforts. This further helps me tailor the best treatment plan for the patient. To learn more about this, please go on my website, weightandmetabolism.com.